So let's take another important topic in CVS, and that's cardiac output. We will define the cardiac output and the introduction related to it. Then major part will be factors determining and influencing the cardiac output, and finally the methods of measurement of the cardiac output and what all questions have been asked or can be asked on this topic. For instance, they can give you the cardiac output and then weight of an individual and body surface area, and then the question can be what will be the cardiac index in this individual. We will see how we calculate that. Apart from that, on methods of measurement, some questions have been asked. For instance, fixed method for measurement of cardiac output, and they can give us femoral artery oxygen concentration, femoral venous oxygen concentration, and pulmonary artery oxygen concentration. And apart from that, oxygen consumption by the entire body per minute has been given, and then they can ask the question to calculate the cardiac output in this particular individual by Fick's principle. Apart from that, there was one question which was asked repeatedly, that dye dilution method for the measurement of cardiac output was to be employed in an individual, and a pharmaceutical company had just brought up a new dye into the market, and it was found that this dye leaves the capillaries very rapidly. Leaves the circulation very rapidly via capillaries. What will be the error in the calculation of cardiac output, measurement of cardiac output by dye dilution method if we use this dye? And there were variations also. For instance, one new dye was brought into the market, and it was found that this dye is sticky. It sticks to the vessel wall after injecting. How will it produce the error in the estimation of cardiac output? So such questions have been asked, or they are likely to be asked, and therefore let's now discuss the cardiac output. First thing, introduction and definition. It's the amount of blood that is pumped by the heart, or pumped by each ventricle, or pumped by the left ventricle per minute. So why I mentioned left ventricle? Because it is the left ventricle which is pumping the blood, and then it circulates throughout the body, which we call as cardiac output per minute. Look, first point, we've got to differentiate between blood volume and cardiac output. Blood volume is the total amount of blood that is there in the body, roughly about 5 liters. And normally the cardiac output at rest is also 5 liters per minute, and therefore very often students tend to confuse between these two. Look, blood volume is 5 liters and it will remain 5 liters unless of course there is hemorrhage and all, but otherwise 5 liters will remain. But cardiac output 5 liters per minute, it's the rate at which the blood is circulating throughout the body, and therefore it can be as high as 25 liters per minute or 35 liters per minute as well, 5 to 7 times higher as compared to the baseline cardiac output. Means same amount of blood is now circulating faster. That's the meaning of cardiac output, and that will depend on the requirement of the tissues. So one must differentiate between blood volume, which is a constant. Cardiac output, it's not a constant. It varies according to the needs of the tissues. Right. Next point. Cardiac output is equal to stroke volume into heart rate. Stroke volume, the amount of blood pumped out by the heart in one stroke or one beat or one systole, one contraction. It is about 70 to 90 ml. Left ventricle will pump out about 70 to 90 ml blood in each systole. And heart rate, number of beats per minute, how many such beats occur every minute? That's about 72 beats per minute. Let's take the average value. So 70 into 72 is roughly about 5 liters per minute. That's the normal baseline cardiac output at rest. And as I mentioned, cardiac output can be also as high as 25 liters per minute in a non-athlete and 35 liters per minute in athletes. Cardiac index. Cardiac index is cardiac output per meter square of the body surface area. So it's 5 liters per minute upon the body surface area of the individual. As I mentioned, they can give you some data and ask you to calculate this. Body surface area in an average healthy young adult is about 1.7 meters square, and therefore the cardiac index is about 2.9 liters per minute per meter square of the body surface area. Let me just tell you that this will have a range. So let me just tell you the range of it. 2.9 to 3.3 liters per minute per meter square of the body surface area. And why there is this range is because cardiac output also can vary from individual to individual, and so will the body surface area, and therefore finally this will have a certain range. You understand the concept of cardiac index. Imagine a newborn baby with a certain body surface area, with a certain body mass. The baby has the same cardiac output, let's say 5 liters per minute, and imagine an obese young adult. Even his heart is pumping, let's say 5 liters per minute. Now cardiac output is the same for both these, in both these cases, but for the baby probably that 5 liters per minute will be excessive, because after all, why the heart is pumping blood to the tissues? For the oxygen supply, and that will depend on the tissue mass. So therefore we need the this cardiac index, that okay, 5 liters per minute is pumped by the heart, but it is going for how much surface area? It means how much tissue mass. Surface area will be indicative of the tissue mass. So that 5 liters per minute is being distributed for how much tissue mass. That's cardiac index. That was the introduction. Next point, factors determining the cardiac output. And we already have two factors with us, isn't it? Cardiac output is a product of stroke volume and heart rate. So we already have two factors that determine the cardiac output, the stroke volume and the heart rate. So let's look at these factors one by one, starting with stroke volume. I mean, it's very obvious that higher the stroke volume, greater will be the cardiac output. Very obvious. Stroke volume itself depends on what? It's determined by what factors? Stroke volume is determined in two ways. First of all, look, stroke volume depends on the strength of contraction of the heart, isn't it? If the heart is contracting stronger, it will eject out more amount of blood in every stroke or every systole. So stroke volume will be higher and cardiac output will be greater. Therefore, we are looking at two factors that determine the strength of contraction of the heart and therefore the stroke volume. Okay, it's intrinsic determination of stroke volume and extrinsic determination of the stroke volume. Intrinsic means something within the heart and regulating its strength of contraction and therefore the stroke volume. Extrinsic means something coming from outside the heart and regulating its contractility. Intrinsic is also called as heterometric regulation and extrinsic is also called as homeometric regulation. We will explain this term just now, these terms. Heterometric means by changing the length of the cardiac muscle fiber, and homeometric means by keeping the length same but producing stronger contraction. So that's basically how we divide the factors. Intrinsic determination or heterometric regulation, of course we are talking about the Frank-Starling law, the Frank-Starling mechanism. Look, we have already done Starling's law in skeletal muscle. What is it? Within physiological limits, greater the initial length of the muscle fiber, stronger is the contraction. We have done that there. Frank-Starling law is the extension of that in the heart muscle, in the case of heart muscle. It says within physiological limits, greater the amount of blood returning to the heart, greater will be the blood pumped out by the heart, greater will be the stroke volume. That's Frank-Starling law. So greater the venous return, more will be the stroke volume and cardiac output. And therefore, stroke volume is proportional to end diastolic volume. End diastolic volume. End diastolic volume is the volume of blood that's filled in the ventricle by the end of the diastole. Normally, it's about 125 to 130 ml. Greater the end diastolic volume means more will be the stroke volume in the next systole. So stroke volume is proportional to the end diastolic volume, which in turn is proportional to the venous return. Venous return. Look, more the amount of blood returning to the heart, more will be the amount of blood filled into the heart during diastole, and therefore greater will be the end diastolic volume, and then in next systole that much greater amount of blood will be pumped out. Okay, so that's the fallout of the Frank-Starling law, and it's very easy to understand. Again, it is related to the length of the muscle fiber. More the venous return, more is the filling of the ventricle. And look, let me just say here that whenever we say heart, it would essentially mean the ventricles, because atria are just the primer pumps. So we are talking about the ventricle. So more the amount of blood filling into the ventricles during diastole, that means greater will be the end diastolic length. So let me just write it here. End diastolic length will be greater. Length of the ventricular muscle fiber by the end of the diastole, that will be greater because more blood is filled into the ventricle. And that means with the next systole, starting of the next systole, that greater length will produce stronger contraction. And if it produces stronger contraction, it will eject out more amount of blood. Stroke volume will be higher. So that is the Frank-Starling law in summary. Well, stroke volume is also directly proportional to the preload on the heart. We have described it in the previous section. We discussed it in the skeletal muscle, then again in the cardiac cycle. Preload is the load on the ventricle before its contraction starts, and that is reflective of the end diastolic volume. More the amount of blood filling into the ventricle, and more is the stretch on the ventricular muscle fiber, there will be a greater preload. And if there is a greater preload, then with next systole, more amount of blood will be pumped out. So please remember, stroke volume is directly proportional to the preload. And let's just complete this particular part. Stroke volume is inversely proportional. Look, this is not concerned with Frank-Starling law. Okay, I'm just adding it, and therefore I'm writing it to the side. Stroke volume is inversely related to the afterload. Please keep this in mind for now. Afterload is the load against which the ventricle is contracting. And we've done this in the previous section, that preload is same on both ventricles, but afterload is greater on the left ventricle, because a load against which the ventricle has to contract, afterload on the left ventricle is aortic pressure, whereas afterload on the right ventricle is pulmonary artery pressure. And therefore, but just remember, if the afterload goes on increasing on the left ventricle, means if the aorta pressure goes on increasing, the stroke volume will fall. It's an inverse relationship. This is just an additional thing because I mentioned preload, therefore I've just completed it by saying afterload, but that's not the point. The point here is these factors that we are discussing. And the first factor, intrinsic or heterometric. You have noticed this point, that heterometric means by changing the length of the ventricular muscle fiber. That's why heterometric. And what is the meaning of that? Look, if the normal end diastolic volume is about 125 to 130 ml, that means by the end of the diastole, that much blood is filled in the ventricle and ventricular muscle fiber will be stretched up to a certain extent. If the end diastolic volume becomes 150 ml, so greater filling of the ventricle during diastole means the end diastolic length will be greater. So that means the heterometric, which we are trying to explain here, is that by increasing the end diastolic length, the next systole will become stronger. That's the first factor. The second one is extrinsic or homeometric. Means here it will not be by changing the ventricular fiber length by the end of the diastole. The end diastolic length will remain what it is. For 130 ml end diastolic volume, whatever is the fiber length, stretch on the fiber, and the fiber length has become whatever it is, it will remain that way. And still the next systole will produce a stronger contraction and more stroke volume. That will then be called as homeometric regulation. Do you understand this? Please, I'm taking more time to elaborate on this because anyways during diastole the length is changing, so people get confused in this. What I mean by heterometric versus homeometric, end diastolic volume is 130 ml. So by the end of the diastole, whatever is the fiber length. Now if the end diastolic volume were to become 150 ml, means increased filling, then the fiber length will be greater. In that sense, it has been called as heterometric regulation, by changing the end diastolic length, by increasing the end diastolic length. Right. Whereas the other factor was homeometric, means not changing the end diastolic length. End diastolic length will remain what it is, and yet stronger contraction. So here we talk about the positive inotropic effect or also called as increased myocardial contractility. Increased myocardial contractility. So I need you to understand this factor, this terminology, that when you say contractility, essentially we are not talking about the Frank-Starling law. Okay, Frank-Starling law also is producing a stronger contraction of the ventricle, fine, but when you talk of contractility, it's not by increasing the length of the ventricular fiber. It is by some other mechanism. We will discuss about that mechanism also. But increased myocardial contractility or positive inotropism, by keeping the same end diastolic length which is there normally, a stronger contraction is produced with next systole. So these are the factors that basically determine the stroke volume. Just let's complete this factor. Increased myocardial contractility is by increased sympathetic discharge, circulating catecholamines, then cardiac glycosides, digitalis, the drug that is given in heart failure, that will increase the contractility. These are the factors that increase the contractility and thereby increase the stroke volume and cardiac output. Right. That was the first factor that determines the cardiac output, the stroke volume. We have seen it just now. The second factor that determines the cardiac output is the heart rate. Obviously, see, cardiac output is a product of stroke volume and heart rate. So if the heart rate increases, the cardiac output will have to increase. Yes, but before we understand this particular factor, I need to explain some other factor related to the heart rate. Look at the background of this. Cardiac output is a product of stroke volume and heart rate, right? Now, if the heart rate increases, you would expect the cardiac output to increase, correct? But no, there is a catch in this. Look, if the heart rate goes on increasing, then the duration of each cardiac cycle goes on decreasing, isn't it? Duration of each beat will be less and less and less. I mean, at 72 beats per minute, each beat has a duration of 0.8 seconds. But if the heart rate becomes 144 beats per minute, double, then each beat will have half duration, 0.4 seconds. If that happens, then if the cardiac cycle duration is less and less, that means the diastole duration will also be less at higher heart rates. And if the diastole duration is less, then ventricular filling will also be compromised. Ventricular filling during diastole will also be less. And if the filling is less, by Frank-Starling law, if the end diastolic volume is less, then stroke volume will become less, isn't it? More the end diastolic volume, more the stroke volume. Less the end diastolic volume, less will be the stroke volume. So what is likely to happen is that heart rate goes on increasing. You should actually expect the stroke volume to fall because diastole length is decreasing at higher heart rates. So then that means cardiac output should never increase actually, because of the heart rate increases, stroke volume decreases, cardiac output remains the same. No, it does not happen like that. I told you just now, that the cardiac output can be as high as 25 liters or even 35 liters per minute. How does that happen? But with this background, let's understand what I told you just now. Look, heart rate increase also increases the cardiac output by certain mechanisms, which I'm going to explain now. First, from 72 to 130 beats per minute. Let's say this is the first step. First increase in the cardiac increase in the heart rate from 72 beats per minute to 130 beats per minute. Increase in the heart rate is not decreasing the stroke volume, it is increasing the stroke volume. I mean, this is not happening actually. It actually increases the stroke volume. How? This is by the so-called staircase effect. We have already described this effect in the skeletal muscle. The effect is increased frequency of stimulation to a muscle. It causes increasing strength of contraction. If you remember this, we have done this in the skeletal muscle, the staircase effect. If the frequency of stimulation to a muscle goes on increasing, then stronger and stronger and stronger contractions are produced. And why this happens? It's because of the increased sarcoplasmic calcium. If the stimulation frequency increases, more and more calcium pours into the sarcoplasm. More and more calcium comes into the sarcoplasm. And we've already seen this, that the strength of contraction of a muscle is proportional to the amount of sarcoplasmic calcium. So if the calcium is accumulating in the sarcoplasm because of a higher frequency of stimulation, then it will produce stronger and stronger and stronger contractions. And stronger contraction of the heart means more stroke volume, greater stroke volume. So that's the first effect, up to 130 beats per minute. Next step, from 130 beats per minute to 160 beats per minute. Even here, increased heart rate. Now see this second effect. You know, up to 130 beats per minute. Okay, let me just, for the sake of clearer understanding, let me come back to this point again. Heart rate is increasing. Means what? SA node is sending more number of impulses into the ventricle. That means what? Increased frequency of stimulation of the ventricle. And that means stronger contraction by the ventricle. I think that was very obvious. But now, staircase effect has reached its peak up to 130 beats per minute if the heart rate has increased. Now, staircase effect has reached its maximum. I mean, imagine we are saying that each beat is producing stronger contraction and therefore stroke volume is becoming greater and greater. But it has got a certain limit. I mean, if see, what is stroke volume? Stroke volume is the limited amount of blood that is ejected out of the heart in each beat. And that's a limited amount of blood. I mean, left ventricle can go on in becoming stronger and stronger. Contraction can become stronger and stronger. But that does not mean stroke volume can go on increasing and increasing and increasing forever. No, it's a limited amount of blood. In one beat, how much can be ejected out? After all, heart can accommodate only a certain limited amount of blood, isn't it? So it can eject out limited amount of blood. And that limit has been reached. Means beyond this, if the further strong contraction is produced, stroke volume will not increase any further now. So it reached its limit. So what happens after 130 beats per minute? Increase in the heart rate. Stroke volume, as I said, will not increase any further because staircase has reached its peak, but it will not decrease also. stroke volume will not decrease also. So neither increase nor decrease. Whatever was reached at 130 beats per minute, that high stroke volume, that will be still maintained up to 160 beats per minute. Now you will say that if the heart rate is increasing from 130 to 135, 140 beats per minute, 145, 150, 160, that means cardiac cycle is further shortening, cardiac cycle duration, and that means diastole is further decreasing in duration. So why stroke volume is not falling now? If the diastole is decreasing and decreasing, that means filling should be affected. And if the filling is less now, stroke volume also should become less. No, I'll tell you the reason why. Because in this range, what happens is diastole is shortened in the duration. Diastole duration shortens in this range. But if you remember, in the diastole there was first rapid filling, diastasis, and last rapid filling. And if you remember what I mentioned about the diastasis, diastasis means diastole stasis, means in that phase not much filling occurs in the ventricle. So if I tell you now that diastasis disappears from diastole, it means what? It means filling will not be affected, ventricular filling will not be affected. So that's what happens, I'll summarize it once again. From 130 to 160 beat per minute, heart rate is increasing in this range. So cardiac cycle duration is shortening, and therefore diastole duration is also shortening. But even if diastole is shortened, filling is not affected yet. Why? Because diastasis, the phase of diastasis disappears from diastole, and there was anyways not much filling during diastasis, and therefore disappearance of diastasis from the diastole will not affect the filling. There will be first rapid filling and last rapid filling, and therefore filling will almost remain the same. And if the filling almost remains the same, it is not affected, then the stroke volume will also almost remains the same. So imagine this, that the heart rate is increasing and stroke volume is remaining constant, which was achieved at 130 beats per minute. That stroke volume is held like that up to 160 beats per minute. What will be the effect on cardiac output? Cardiac output will still increase because heart rate is increasing. No? It's a product of these two. So that's what happens in this range of heart rate. Therefore, notice one point, and that is up to 130 beats per minute, increase in the heart rate is happening. Cardiac output is increased by both the stroke volume and heart rate. Cardiac output will be driven by stroke volume and heart rate. Both these factors, both are increasing. And from 130 to 160 beats per minute, cardiac output will be mainly driven by the heart rate. Increasing heart rate, therefore more blood circulating or increased cardiac output. Stroke volume was held almost constant. And now we come to the real part, and that is what happens at 160 beats per minute. 160 beats per minute. This is the highest heart rate up to which stroke volume could be maintained. When this heart rate is achieved, now the filling will dramatically suffer, because now the cardiac cycle duration and diastole duration is so less that filling will now be affected. So please remember, what is the highest ventricular rate up to which filling can be maintained and therefore stroke volume can be maintained? It is 160 beats per minute. And the last point is 160 to 180 beats per minute. What happens is heart rate increases but stroke volume decreases, and therefore cardiac output, which was achieved for 160 beats per minute, it can be maintained up to even 180 beats per minute, and more than 180 beats per minute heart rate, cardiac output will be now dramatically reduced. cardiac output will be very, very low. It will be tough to maintain the cardiac output, and it will be tough to maintain the tissue perfusion, because now up to 180 beats per minute and beyond, filling will be virtually very, very less, and therefore stroke volume, which is proportional, that will also be very, very less. Okay, therefore these are the milestones in the heart rate and its influence on the cardiac output. There was a question, a clinical type of question. A 40-year-old person is on the treadmill. On the treadmill, what will be that person's HR max? And the options given are 160 beats per minute, 180 beats per minute, 200 beats per minute, or 220 beats per minute. 160, 180, 200 or 220. What will be the heart rate maximum for a 40-year-old, let's say, athlete or physically active person, and he's on the treadmill? So what's your answer on this? Well, yes, because there is a formula for the measurement of heart rate maximum. It's called as Karvonen formula. It says HR max, maximum achievable heart rate up to which cardiac output can be maintained. It is 220 minus age in years, right? Therefore, you should be able to dissect out the data which is given in that particular question which I mentioned. Why is the age given? This is the reason. Okay, so I will always maintain this, that it is said that now the exam pattern will be mostly on the clinical questions or problem solving type questions or case based questions, where you will have to have that problem solving ability. That's fine, but you will basically need to have a good conceptual understanding of the subject, right? So these were the factors that determine the cardiac output. Let me just also enumerate those effects on the heart. Chronotropic, dromotropic, you might have heard those terms. So chronotropic effect, it is the effect on the heart rate. So sympathetic nerves have positive chronotropic effect. Parasympathetic nerve, the vagus, has negative chronotropic effect. It decreases the heart rate. Second, what is dromotropic effect? Effect on the conduction speed. Speed of conduction of one impulse. How rapidly it will go through the AV node and will spread into the ventricles. That conduction speed is called as dromotropic effect. Again, sympathetic nerves will have positive dromotropic effect, means they increase the conduction speed, and the vagus will have negative dromotropic effect. Third, and the most important one which we often require, is inotropic effect. By the way, please note the spelling. Very often when I get doubt from the students and they want to mention inotropic effect, they inadvertently write IONO, ionotropic effect, as in ion. So please note, it's not IONO, it's inotropic effect. If you want to keep it in mind, keep it as inotropic effect, just for your understanding and clear spelling. Okay, so inotropic effect is the effect on contractility of the myocardium or ventricular contractility. Sympathetic nerves have positive inotropic effect. Vagus does not have a negative inotropic effect, at least not direct effect, because vagal innervation is mainly to the conducting system of the heart and to the atria, but not to the ventricles. and therefore vagus does not directly influence the contractility of the ventricles. Look, I already told you heart will essentially mean the ventricles. We are talking about the ventricles, right? So inotropic effect. The fourth one is bathmotropic effect. This effect is increase in, or rather the effect is on the general excitability in the heart. So sympathetic nerves have positive bathmotropic effect, vagus has negative bathmotropic effect. Well, there is one more, and that is lusitropic effect. Well, I have seen different spellings for this. Some people write it as lusitropy. Some people write it as luciotropy. O is added here. What is the effect? The effect is the effect on relaxability and diastolic function. Relaxability and diastolic function, the effect on that is called as lusitropic effect. Again, sympathetic nerves have positive lusitropy, and vagus does not have a direct effect because it's not innervated into the ventricles. So I mean, when I say positive lusitropy, it would mean a better expansibility of the ventricle during diastole. Now I want you to understand, I want to bring to your notice one more fact related to these. We are saying that the sympathetic innervation, or better we say circulating catecholamines, they increase the heart rate, right? Positive chronotropic effect. And they also increase the stroke volume. I mean, by increasing the contractility, they also increase the stroke volume. Now my question is, how is this possible? Because increased heart rate means decreased cardiac cycle duration, cardiac cycle length is decreased, and that means there is decreased systole duration and there is decreased diastole duration. Try to understand what I am trying to explain. If the heart rate increases under the influence of catecholamines, it will reduce the cardiac cycle duration. Cardiac cycle length is shortened. That means systole will also be shortened and diastole also. But remember, diastole duration decreases to a much greater extent. But anyways, both are reducing in duration. Fine. Now, if the systole duration is decreased, how can the stroke volume increase? Stroke volume is the amount of blood ejected during systole. So, if the systole duration itself is less, then how come stroke volume increases? Yes, it does. Then second point, if the diastole duration also decreases at higher heart rates, then filling will suffer, and if the filling suffers, then the stroke volume should also suffer, isn't it? Then how come stroke volume is increasing under the influence of catecholamines? Yes, let me explain that. Even if systole duration becomes less, in that lesser duration, stroke volume can increase. It can be higher. How? Because of the influence on the cross bridge cycling. The catecholamines, they have the influence on cross bridge cycling. And if you remember, in the skeletal muscle, we have said that the amount of tension that is developed during the contraction, it depends on the cross bridge cycling. So actin-myosin interaction is made better under the influence of catecholamines. And if that happens, then the peak tension development also is greater. It has been described as delta P by delta T. That means change in the pressure per amount of time that the contraction happens. What I'm trying to say is, even with less duration of systole, the peak tension that was developed during systole will be higher. Means stronger contraction will be produced in lesser time. And that means more blood can be ejected out. Stroke volume can be higher. Okay. I'm trying to explain to you the effect of catecholamines, how they increase the heart rate and at the same time they can also increase the stroke volume. How is that possible? I'm trying to explain that. So increase heart rate means decrease cardiac cycle duration. So systole duration and diastole duration also, both these durations will decrease. If systole duration is less, we will expect that the stroke volume should be less because less amount of time is available for ejecting out the blood. But no, that's not happening because of this effect of catecholamines. Now coming to the effect on diastole. If the diastole duration is less, then in higher heart rate, if the diastole duration is less, that means filling should be affected. And if the filling is affected, stroke volume should be less. It should not increase. But no. Increase heart rate and therefore decrease diastolic length. You know, the effect on lusitropy. Catecholamines have effect on lusitropy. We are talking about the relaxation of the heart muscle during diastole. Before I explain it, let me just revise it. In the case of muscle, there is a protein called as SERCA, SERCA, sarcoplasmic endoplasmic reticulum calcium ATPase. When this ATPase removes the calcium from the sarcoplasm, then there is relaxation, right? Yes. Now in the case of heart, there is a protein present in the heart and that protein is called as phospholamban. Phospholamban is a SERCA associated protein specifically in the heart. This phospholamban, it normally keeps the SERCA slightly inhibited. It slows down the action of SERCA. So, because of that, the removal of calcium from the sarcoplasm is slightly slower under the influence of this phospholamban. And because of that, the relaxation also of the ventricle during diastole will also be slightly slower. Catecholamines, now listen to this part carefully. Under the influence of catecholamines, what happens is that they cause phosphorylation of phospholamban. Phosphorylation of phospholamban leads to what? Their inhibitory check on SERCA is lifted. And that will result in what? That means now, under the influence of SERCA, there will be a more rapid reuptake of calcium, more rapid removal of calcium from the sarcoplasm. That means what? There is a faster relaxation rate during diastole. Okay? Because calcium is rapidly removed from the sarcoplasm, because that's the effect of catecholamines by causing phosphorylation of phospholamban. So, it means that although catecholamines, they increase the heart rate, and that means cardiac cycle duration has become short, diastole duration has become short, but in that shorter duration of diastole, there is better expansibility. Okay, better expansibility, I mean greater expansion during less duration. In the lesser duration, the ventricle expands more because of this effect which I told you just now. And if it expands more, it will receive more amount of blood. And if it receives more amount of blood, stroke volume can be higher. So, that is how catecholamines, on one hand, they increase the heart rate, but at the same time, they can also increase the stroke volume and cardiac output. They have effect on the systole, they have effect on the diastole. The durations of systole and diastole are reducing by increased heart rate. Yet, in those less durations, there is a better performance by the heart under the influence of catecholamines. Right. These were the factors determining the cardiac output. Let us also quickly see the factors influencing the cardiac output. Physiological factors. I am going to name only a few important ones. Well, I am going to just join these factors with the stroke volume and heart rate. For instance, let's say respiration, or to be more precise, let's say inspiration. What is the effect? You know, negative intrathoracic pressure. If you make a forceful inspiration, the intrathoracic pressure becomes more negative, and that means more blood will be sucked towards the heart. So remember, forceful inspiration increases the venous return to the heart, because more negative pressure, it will suck more blood towards the right side of the heart. So venous return increases, and therefore filling and stroke volume will also increase. Apart from that, muscle activity as a pump. You know, particularly when you are performing muscular exercise, muscle acts like a pump, and it squeezes those blood vessels or pumps those blood vessels within the muscle. That means what? That means the blood going out of the muscle and returning to the heart will increase. So there is increased venous return, and therefore increase end diastolic volume, increase stroke volume. So that's another factor that influences the stroke volume and cardiac output. Apart from this, of course, exercise, anxiety, emotions, all these factors will increase the cardiac output. There is increased sympathetic discharge in these, so stroke volume, heart rate, both will increase. Physiological decrease is seen in the sleep. You know, in the sleep, the basal metabolic rate is less. The BMR during sleep is only 90% of the waking hours. So less BMR, that means less requirement of oxygen by the body, and therefore less cardiac output. Posture. You know, recumbent to standing posture, this change of posture from lying down to standing, the venous return decreases to the heart because there is pooling of blood in the lower limb veins. So since the blood is pooled in the lower limbs, therefore by gravity, of course, less blood will return to the heart, and therefore stroke volume will be less. You will have experienced this whenever you get up suddenly from lying down to standing posture. There is a half a second or 1 second of giddiness that is felt sometimes. So that's because of a decreased cardiac output and decreased blood pressure. In fact, less blood in the cerebral circulation. Then of course there are other factors like pregnancy, for instance, increased cardiac output. Pathological factors. I'll just name a few important ones. Increased cardiac output will be seen in anemia. Now that's logical. If the RBC count or hemoglobin is less, That means there will be a less oxygen supply to the tissues, and therefore to compensate for that, heart will have to pump more amount of blood. I'm just explaining the logic behind it. Hyperthyroidism, again quite obvious to understand. Thyroid controlling the BMR, so increased BMR, increased cardiac output. On the other hand, decreased cardiac output will be seen in what? Let's say myxedema or hypothyroidism by a decreased BMR and decrease in the cardiac output. Congestive cardiac failure. Heart failure is a condition in which there is a pump failure. So stroke volume goes on decreasing. These were the factors influencing the cardiac output. Now finally, we will discuss the methods of measurement of the cardiac output. And I have already described one question, or in fact two questions which I mentioned. Methods of measurement. Okay, first method is based on, actually it's called direct Fick method. Based on the Fick principle and Fick equation named after Adolf Fick. This is a Fick's method based on the Fick's principle. The equation is cardiac output is equal to, cardiac output in per minute is equal to oxygen consumption by the entire body in ml per minute, because it's a per minute consumption, upon arteriovenous oxygen difference, again for the entire body. Okay, let me just point out one thinking flaw. When the students see this equation, they think of just one organ and they say, sir, arteriovenous oxygen difference means arterial oxygen level, venous oxygen level, and the difference between the two. Look, now you are thinking about one organ or one tissue. So artery going into that organ and vein coming out of that organ. That is what you some students think. So whatever is the difference between the two samples, artery and venous sample, that difference will be same as the oxygen taken out by the tissue, oxygen consumed by the tissue. So that's what the students think. They think that this should be equal to 1. No, that's a faulty thinking. I mean, they think, okay, this difference should be the same as the amount of oxygen that was consumed by the tissue, extracted by the tissue. So numerator and denominator should be same. That is what some people believe. No, it's not correct. First of all, please try to understand that we are talking about the entire body. Okay, we are not talking about one organ. So some tissues extract less oxygen, some tissues extract more oxygen, and arteriovenous difference also is for the entire body. I'm going to explain this further, but just remember this one fact. And the second point is, they cannot be same values, because numerator is ml per minute by the entire body and denominator is only ml. I mean, arterial oxygen level, venous oxygen level, and the difference between the two. So it will be only ml. Okay, whereas numerator is ml per minute. So this is just one point of time, one time difference between these two samples, whereas that is per minute for the entire duration of 1 minute. So these are not the same units also, numerator and denominator, and therefore it can't be same numerator and denominator. So oxygen consumption by the entire body in ml per minute. Now come to the denominator. We will need arterial sample for its oxygen level, and arterial sample can be collected from any peripheral artery, because you select any artery, the oxygen level is the same in all the arteries up to the till the blood reaches the tissues. All arteries have same saturation level and same amount of oxygen level. So you can select any artery, it doesn't matter. Femoral artery doesn't matter. Venous sample. I hope you understood what I said. Artery, any sample, any artery can be taken for sample collection, because all arteries will have same amount of oxygen, and therefore any arterial blood will be representative of the entire body. We want representative sample. We are talking about the cardiac output, which is for the entire body. So we want a sample which is representative for the entire body. Femoral artery, yes, it will have same oxygen as any other artery. So it will be a representative sample. Venous sample, can you take from femoral vein? No. Even if you have taken femoral artery, you can't take femoral vein. You know why? Because a particular vein coming from a particular part of the body, this venous sample, and I'm talking about oxygen level in the venous blood, it will depend on the oxygen consumption by that part of the body. I mean, imagine that one part of the body is consuming more oxygen, then the venous blood coming from that part will have less oxygen, because more oxygen was taken out by that tissue or organ. So venous blood returning from that tissue will have less oxygen in it, isn't it? And that will not be the representative sample for the entire body, because in our body some organs are metabolizing more, some are less at any given point of time. So we are looking at body as a whole, and we are looking at not just one organ. So we want representative sample for the entire body, and that is taken from the pulmonary artery. Remember this. In the question, they will give you femoral artery sample, femoral venous sample, and the data, and the pulmonary artery oxygen level. So you will have to take that instead of femoral vein. Okay. Why? Because entire body's venous blood comes to the right side of the heart, and from the right ventricle it comes into the pulmonary artery. Now it is the mixed venous blood. Many students ask me this question, sir, what is the meaning of mixed venous blood? So all veins coming from all over, they have different amounts of oxygen, and when they come to the right ventricle, it gets mixed there. Entire body's venous blood gets mixed there, and then it is pumped into the pulmonary artery. That's called as a mixed venous blood. It's properly mixed, and therefore now that is the representative sample for the entire body. So that is how fixed method. By this method you get the cardiac output in ml per minute, and then you can convert it into liters per minute. Second method, dye dilution method. We have already discussed it in the first chapter, body fluid compartments. It's based on the Stewart-Hamilton, it's sometimes called as Stewart-Hamilton dye dilution technique. It can also be called as indicator dilution method. The same method is also used for measurement of the body fluid compartments. If you remember, we have done that chapter at the very start of physiology, and there we inject a known initial volume of the dye in that particular compartment. Then the dye gets distributed into that entire compartment, and then we collect the sample and take the concentration of the dye. So it was V is equal to I upon C. That was the equation that we used. I was the initial volume of the dye injected, and then it got dispersed into that compartment, and then we collected the sample and measured the concentration of the dye, and then that tells you the volume of that compartment. Yeah, this was for the body fluid compartment. Before I move on, let me just give you one more question to think over. A dye dilution technique was being used on an individual for measurement of ECF volume and cardiac output. ECF volume, the body fluid compartment, and the cardiac output measurement. But it was observed that this dye is leaking out of the capillaries very rapidly. And here I am saying systemic capillaries only. Please remember, generally when the substances leak out of the capillaries, we are talking about the systemic capillaries in the tissues. We generally do not consider pulmonary capillaries for this. Pulmonary capillaries are generally not leaky. They don't leak out the substances that much. So when we consider the capillaries, it's the systemic capillaries. So the dye was leaky. It leaks out of the capillaries very rapidly. How will it affect the measurement of ECF volume and cardiac output by dye dilution method? And the options given are falsely high cardiac output and ECF volume will be measured. Falsely low ECF volume and cardiac output will be measured. No change in the ECF volume, no change in the cardiac output, or increase ECF volume and decrease cardiac output. So these were the options given, and let me tell you the answer. There will be no change in the cardiac output, no change in the ECF volume measurement. Yes. Why? We will see it just now. First of all, the principle, dye dilution technique principle. Inject a known amount of dye, known initial volume of the dye into a vein. Okay, a dye is taken, known initial volume is taken, and that known initial volume we will take it as I. It's injected into the vein. From the vein it goes into the heart. The dye goes into the heart, all of it, and from the heart it is pumped out. I mean, stroke volume pumps it on the arterial side. So now dye starts coming on the arterial side. Okay, we collect continuous samples now from the arterial blood. Okay, for the dye concentrations. Every 2 seconds or every 5 seconds we will collect the arterial blood. The dye is now coming into the arterial blood. So we will start collecting the samples immediately. Every 5 seconds we will collect the sample and we will measure the dye concentration. Okay, so let's say we have collected 10 samples. Now what is going to happen? We injected a certain amount of dye, but as it starts coming on the arterial side, the most important part is the stroke volume dilutes the dye. First of all, two things to be considered. One is, in each sample that we collected, the dye concentration is going to fall, because obviously there was a limited amount of dye that we injected. So as the blood starts taking that dye on the arterial side, in each sample its level is going to fall and fall and fall, right? And we'll collect 10 such samples. All dye was collected from the arterial side. Anyways, not all, but major part of it, right? Now yeah, most important part is stroke volume dilutes the dye. That's the most important part that you need to understand. Look, imagine a person with stroke volume of 70 ml. and imagine another person with a stroke volume of 100 ml. I am just trying to explain this method to you, okay? Imagine a person with 70 ml stroke volume and another person with 100 ml stroke volume. If you inject same initial volume of dye in both these people, the dye is going to be diluted by the stroke volume. So, the person with a stroke volume of 100 ml, the dilution of the dye will be to a greater extent. Isn't it? Greater stroke volume. That means the dye will be diluted faster. Isn't it? And that means when it comes to the arterial side and you start collecting the samples, and then we take the mean concentration of the dye, because we have collected 10 samples. So from that we will calculate the mean concentration of the dye. So suppose the stroke volume of 100 ml, the dilution of the dye will be larger, greater extent, because stroke volume is diluting the dye and stroke volume is higher. So concentrations may be 10, 5, 2. The dye diluted faster. Whereas somebody with a stroke volume of 70 ml means stroke volume is less. So dilution of the dye will be to a lesser extent. Less dilution of the dye. So maybe in successive samples the concentration will be 10, 8, 6, 4, 2, like that. And therefore, when you see the mean concentration, when you calculate the mean concentration of the dye from these concentrations, the mean concentration will be less if the stroke volume is more. Remember this. If the stroke volume was 100 ml, dilution of that dye was much faster. So dilution is greater means concentration and mean concentration will be lesser. Yeah, greater dilution means lesser concentration. So mean concentration will be less if the stroke volume is more. And now we take the formula. F is equal to I upon C. Look, in the body fluid compartments, we had V is equal to I upon C. Here it is F, that is flow or cardiac output, is equal to I upon C into T into 60. So I upon C is common. T and 60 are the additional things. So let me just tell you, cardiac output, flow or cardiac output is equal to I is initial volume of the dye that was injected. C is mean concentration of the dye, because we have collected 10 samples, then from those 10 samples we had 10 concentrations. So we calculate the mean concentrations from those 10 samples. In the body fluid compartments measurement, we had just concentration of the dye after it got dispersed, because we only collected one sample for the concentration. T is time in seconds at which the dye appeared in the artery, means appeared on the arterial side for the first time. For the first time means after that it will keep coming. See, it's the circulation time. If you have heard of this concept of circulation time, we'll take it at some other section. You inject the particular substance in the arm vein, and then when it comes to the tongue, for instance, it's called as arm to tongue circulation time. It's in seconds, 15 seconds, or arm to arm vein to the artery, it's 24 seconds. So it's a circulation time, basically time in seconds at which the first dye came into the arterial side, and then it will keep on coming. Each stroke volume will keep on sending the dye with less and less concentrations, right? In fact, you can see that this itself gives us the idea whether the cardiac output is high or low. If the cardiac output is high, means there is a hyperdynamic circulation. And if the hyperdynamic circulation is there, that means the dye will come very rapidly in the arterial compartment. That means the time t will be less. In less time, in less seconds, the dye will appear on the arterial side. That means if the t is less, denominator is less, that means cardiac output will be more. So it's a fair judgment that can be taken from the t itself. And of course, as I already mentioned, C, the mean concentration, if it is less, in the denominator C is there, if it is less, that means the dye was diluted very rapidly, and that means stroke volume was higher. Therefore, dye was diluted very rapidly in successive samples, and therefore mean concentration is less. That will mean cardiac output will be more, stroke volume will be higher. So that is the base. And finally the 60 thing, because we have taken t in seconds, t is taken in seconds, and we want the cardiac output per minute, so we will multiply it by 60. This is the dye dilution method, and that is the basis. Now coming to our question, first question which I asked you is that a dye is leaky. It leaks out of the capillaries very rapidly. How will it influence the measurement of cardiac output by this principle? Well, there will be no effect on cardiac output measurement, because this is a trick question actually. Why? Because look, the dye was injected into a vein. It went to the heart, then it went to the arterial side, and we collected the sample. We started collecting the sample from the arterial side. After that, it will go to the systemic capillaries. Capillaries will come after the artery, isn't it? So once we have collected the samples one after the other, and it is going to the capillaries, after that it doesn't matter if it leaves the compartment via the capillaries. It's actually good, because we are not interested in the recirculated dye. I mean, it goes to the capillaries, then it comes back to the vein and heart, and then again comes to the artery. We are not interested in that's recirculation of the dye. We are collecting the dye only for the first appearance. I mean, from the vein to the heart, heart to the artery, we collect the sample, and that's it. It's the stroke volume which we are actually measuring. So after that, it goes to the capillaries, systemic capillaries, okay, and it goes out of the circulation. Good. In fact, that will be a good dye, because then it will not circulate much. It will not be recirculating and coming back. So if it goes out of systemic capillaries, it will not influence our cardiac output measurement. Okay, but I made an assumption here. An assumption was made, that is, it's only leaking out of systemic capillaries. Then it will not influence our measurement of cardiac output. But what if the dye leaks out of pulmonary as well as systemic capillaries? All capillaries of the body. So pulmonary capillaries. Then what happens? Then, I mean, if the dye leaks out of pulmonary capillaries, that means then it goes to the left side of the heart, and then it's pumped into the artery. That means on the collection point, less and less dye will reach, isn't it? Because some dye has leaked out of pulmonary capillaries. Look, vein to right side of the heart to the pulmonary vessels, and pulmonary vessels to left side of the heart, and then goes to the arteries. So if it goes out of pulmonary capillaries, then it comes less and less dye is coming on the arterial side. So that means the denominator C will be erroneously less. Less dye is coming to the arterial side. So C will be erroneously less, and that means cardiac output will be erroneously high in that case. Okay. So please see the question. If they are mentioning systemic capillaries, if they are mentioning pulmonary capillaries, but I'll tell you one thing. If they are saying only capillaries in the question, that the dye leaks out of capillaries, then you should assume only systemic capillaries, okay? Because when we say something is leaking out of the capillaries, generally it is considered to be the systemic capillaries. The Starling's equilibrium generally works in the systemic capillaries. So that distinction should be made. Okay, let me give you, let's see, now I asked you the question, before that, yeah. What about the ECF volume? V is equal to I upon C. That was for ECF volume. If the dye leaks out of the capillaries, how will it influence the measurement of the ECF volume? Okay, again no change, because look, we injected the dye in a vein and it's circulating in the plasma. Okay, if it leaks out of the capillaries, it goes into the interstitial fluid. And when we say ECF volume, it is plasma and interstitial fluid volume. So if the dye goes out of the plasma, it goes into the interstitial fluid. That's fine. It is still in the ECF compartment and therefore it gets diluted. So no effect on the ECF volume also, if the dye goes into the interstitial fluid, because that is a part of ECF and we are measuring the ECF volume. Okay. So if the dye goes out of capillaries, no change in the ECF volume measurement, no change in the cardiac output measurement. Okay, I'll just check whether you have understood this concept. A dye is leaky and dye is sticky. We have seen the leaky dye just now. If the dye is sticky and it sticks to the vessel wall, how will it affect the measurement of cardiac output? The dye was injected in a vein and some of it is getting stuck, sticky dye, so it sticks to the vessel wall. What will be the error in the measurement of cardiac output? You just have to, in all such questions, you just have to look at the equation and answer the question. If the dye is sticky, it sticks to the vessel wall, that means at the collection point, less and less dye is reaching, because some of it has got stuck to the vessel wall. So less dye reaching at the collection point of the artery, that means your mean concentration C will be erroneously less. That means erroneously higher cardiac output will be measured, obvious. Okay, one more, last one. What if there is a ventricular septal defect? How will it influence the measurement of cardiac output? A person had ventricular septal defect and cardiac output measurement, for that method dye was injected. What will be the error? Come on, think over this. Okay, I'll give you a hint. Ventricular septal defect and left ventricle has got a higher pressure than the right ventricle. That's your cue. So think about this cue and answer the question. Again, error in the cardiac output will be erroneously higher cardiac output will be measured. You know why? Because the dye which you injected, it went into the heart. From the left ventricle, it was, let me just draw it here. Here is a right and left ventricle. The dye came in the left ventricle and now it is going to be pumped into the arterial side and we will collect the sample in the artery. But ventricular septal defect means some of the dye will again go back from left ventricle to right ventricle. That means all that dye which you injected is not going to be immediately pumped into the arterial side, all of it. So when you start collecting the sample, you are going to actually get less and less and less dye because some of it went back. It's getting recirculated. So error is going to happen, and that error is mean concentration of the dye that you calculate will be actually less, because dye is trickling very slowly into the arterial system. Some is going back, some is getting pumped forward into the arterial side. So in ventricular septal defect, mean concentration C of the dye will be less, erroneously less, that is denominator is less, therefore erroneously higher cardiac output will be measured. So this is how you should apply your present understanding. I mean, the question could be just a ventricular septal defect boy went to the hospital, it was brought to the hospital, and this method was to be employed. So what will be the error? Now this is a problem solving type of MCQ. If you knew this and you knew the method, your answer will be always correct. So please keep your concepts always very clear on this. But let me just end it by saying that this method is not reliable under certain conditions. Not reliable in, say, septal defects. As I told you just now, the dye is going back and forth, or valvular heart diseases, regurgitant valves, regurgitation conditions. The method will be unreliable because suppose there is aortic regurgitation, left ventricle pumping the dye, some of it will regurgitate back. So, back and forth of going of the dye, and therefore the method will become unreliable. So that was dye dilution method. Finally, look, these are all older methods. Now with the advent of technology, we have lots of other methods. First, there was plethysmography. This method also can be used. It's based on the limb diameter and how much blood going into the limb and how much blood is coming out of the limb per unit time, and the limb diameter is changing accordingly. So that is the basic principle. And of course we have echocardiography. This will be of course the most commonly used method, technologically most sound, and errors will be less. This was the topic of cardiac output.